Hi, welcome to the second lecture of the anatomy of the upper extremity. A good source that you can use to study for your final exam is this book written by myself, The Guide to Pass the Final Orthopedic Exam. So let's start with some elbow approaches that come frequently in the exam. We have the anterior approach to the biceps tendon. So patients who have like biceps rupture and you're doing the anterior approach to the elbow to reattach the biceps tendon. Remember, the most commonly injured nerve is not the PIN. It's not the posterior interosseous nerve, which is very close, of course, to the insertion of the biceps tendon at the radial tuberosity. It's actually the continuation of the musculocutaneous nerve, which is the lateral antebrachial cutaneous nerve. So the most common injured nerve and the most common nerve complication is irritation of the lateral antebrachial cutaneous nerve, which is the continuation of the musculoskeletal, and it's not actually an injury to the PIN. Now let's speak about the lateral approaches to the elbow. There are two main intervals, the Kaplan interval and the Coker interval. The Coker interval is the very classic lateral approach to the elbow between the anconeus posteriorly and the extensor carpi ulnaris anteriorly. So you go into this interval. Again, this is the most classic approach to the elbow. People, however, are not doing it as much now because of the fear to the injury of the lateral ulnar collateral ligament. The ulnar collateral ligament basically lies under the anconeus. So when you do this approach, you're very close to the ulnar collateral ligament. So less people are using the classic Coker, and more people now are using the Kaplan interval. The Kaplan interval is in between the extensor carpi radialis brevis and the extensor digitorum communis. So it lies in between, so it's more anterior. So the anconeus and the extensor carpi ulnaris is here, so this is the classic Coker. The Kaplan is anteriorly. It lies between the extensor carpi radialis brevis and the extensor digitorum communis. Usually when you do these surgeries, usually there is disruption of this area, so it's not easy to identify the interval here. However, it is basically direct approach to the elbow laterally, and you don't go posterolateral as the classic Coker approach. So you have the classic Coker approach between the anconeus and the extensor carpi ulnaris, which is this approach here, or the more direct approach, which is in between the extensor carpi radialis brevis and the extensor digitorum communis. The disadvantage of the classic Coker approach is very close to the ulnar collateral. Of course, when you go anterior, you're further away from the ulnar collateral. However, you're coming closer to the posterior interosseous. In general, or in all lateral approaches to the elbow, the forearm should be kept pronating. So if you're doing the surgery for radial head fracture or radial neck fracture that you're putting internal fixation, the whole case you need to have the assistant pronating the forearm, because that will push the posterior interosseous more further away from your incision and further away from your approaches. So all through the whole approach, you have to keep the forearm pronate. So two interval, Kaplan and Coker. Coker is the classic one. It's more posterior between the anconeus and the ulnaris. The disadvantage is you're coming very close to the ulnar collateral. You can go slightly more anterior. However, you're coming close to the posterior interosseous, but you're staying further away from the ulnar collateral. In all approaches to the lateral approach to the elbow, keep the forearm pronated through the whole procedure to get the posterior interosseous away from your field. Regarding the portals for elbow arthroscopy, there is the posterior portal, which is 3 centimeters from the tip of the olecranon, and the posterolateral, which is also 3 centimeters proximal to the olecranon, but lateral to the triceps. Also, there is the anterolateral border. Remember that the anterolateral border has a risk of injuring the radial nerve or the posterior interosseous. The radial nerve and the posterior interosseous are assessed by extension of the metacarbophalangeal joint, not the interphalangeal joint. The interphalangeal joint extension is by the intrinsics of the hand, which is the lumbricals and the interossei, If you want to assess the posterior interosseous, you're assessing the extension of the interphalangeal joint. So we said we have the posterior portal, the posterolateral border, the anterolateral border. There is also the anteromedial border. The anteromedial border has some risk of injuring to the medial nerve and the medial antebrachial cutaneous nerve. So that's why people go more to the proximal anteromedial, so it's slightly more proximal. It has less risk of injuring the median nerve. So we have the posterior, posterolateral, anterolateral, and the anteromedial and the proximal anteromedial. The anterolateral has some injury to the radial and the posterior interosseous. The anteromedial has some possible injury to the median nerve and the medial antebrachial cutaneous nerve. Remember, there is nothing called posteromedial because posteromedial approach, this which is here, will be very close to the ulnar nerve, so that portal is not used anymore. So posterior, posterolateral, anterolateral, and anteromedial and posterior and proximal anteromedial. Now let's speak about the elbow anatomy. The first thing that we're going to talk about that commonly come in the exam is the medial collateral ligament. The medial collateral ligament consists of three components. First part of the anterior band of the medial collateral ligament, that's the most important part. You have also the posterior band and the transverse component. The medial collateral ligament arises from the anteroinferior. It arises from the anteroinferior surface of the medial epicondyle. So it arises from the anteroinferior surface of the medial epicondyle. So the most important part of the medial complex, as we said, is the anterior band. So the anterior band is the primary stabilizer against the valgus stress, whether the elbow is in flexion or extension. And that anterior band, as we said, originates from the anteroinferior surface of the medial epicondyle and it inserts into the sublime tubercle of the coronoid. So the anterior band is the primary stabilizer to valgus stress. Whether it's in flexion or extension, it arises from the anteroinferior portion or the surface of the medial epicondyle into the sublime tubercle of the coronoid process. The posterior band is only tight in flexion, and it resists it's part of the stabilization against valgus stress from 60-degree to full flexion. So the primary stabilizer to valgus, whether in flexion or extension, is the anterior band of the medial collateral. The posterior band plays role in flexion between 60-degree to full flexion. One of the important concepts in the elbow anatomy is the muscle action. So we have the biceps muscle. We talked about it, long head that originate in the shoulder. We talked about it, the shoulder part, the short head from the coracoid. They unite and they form the biceps tendon that inserts into the biceps tuberosity in the radius. The biceps muscle is mainly responsible for the supination. So it moves the arm from pronation to supination. So that's the main action. So they may give you a scenario. The diagnosis of that scenario is rupture of the biceps tendon. They will tell you what is the most affected function. It is not elbow flexion. It's actually supination of the forearm. So the biceps brachii muscle, it is the main supinator. So it moves the forearm from pronation to supination. The main elbow flexion strength comes from the brachialis muscle. So the brachialis muscle, this is the main muscle responsible for elbow flexion strength. So the cubital tunnel, very important part of the elbow anatomy. The cubital tunnel is where the ulnar nerve will basically pass to go to the forearm. The cubital tunnel roof is the Osborn ligament or the cubital tunnel retinaculum. It goes from the medial epicondyle to the olecranon. This is the roof. The floor is the posterior band of the MCL. So the floor is the posterior band of the MCL. The roof is the Osborn ligament or the cubital tunnel retinaculum. So the ulnar nerve will go pass in between these two. Laterally, it is the olecranon process. So the lateral structure in the cubital tunnel is the olecranon process. So the proximal radioulnar joint, there is a very important anatomic fact that is important when you're doing internal fixation, because that's the area that you should put your internal fixation, because it will never articulate between the radius and the ulna. So about 1/3 of the radial head will not articulate with the ulna, whether in supination or pronation. So when supinate and pronate, different parts of the radial head will articulate with the sigmoid notch here in the ulna. However, there is about 1/3 of that arc of radius will not articulate here in any position. It's about 100-degree arc, and that 100-degree arc corresponds to the area or the part from the Lister tubercle here to the radial tuberosity. So this is very important, because when you put internal fixation proximally, you want to put it in an area that will never go into the sigmoid notch or the proximal radioulnar joint in any position. So you need to put it in an arc that is between the corresponding to the area between the Lister tubercle and the radial tuberosity. So from here to here, part of that radial head, so that part of the radial head here, which corresponds from the Lister to the radial tuberosity, will not articulate with ulna, whether in supination or pronation. It is very important to know the sequence of the appearance of the different epiphyses in the elbow. The sequence you can remember with the word cretoi. The C here is the capitellum. The R is the radial head. The I is the medial epicondyle, or you can call it internal epicondyle. And then the T is the trochlea, which is here. And then the O is the olecranon. And the E is the lateral epicondyle, or you can say the external epicondyle. So you can use the word cretoi, and this will tell you the sequence of the appearance of the different epiphyses in the elbow. And they appear at 1, 3, 5, 7, 9, 10. So the capitellum will appear at age of 1, radial head at the age of 3, internal epicondyle or the medial epicondyle at the age of 5. At the age of 7 is the trochlea, and the olecranon at the age of 9, and then at the age of 10 is the lateral or the external epicondyle. And these ages are in female. In male, it can go 1 or 2 years after that, except the capitellum will also appear at 1. So in girls it will appear 1, 3, 5, 7, 9, 10. In boys it will appear 1, 5, 7, 9, 11, and 12. Or it can go only 1 year after the female. Remember that this here, this physis here between the medial epicondyle and the humerus is the last to fuse. It fuses in boys at the age of around 18-year-old and 2 years earlier in female. Now let's go to the forearm and speak about the forearm approaches. The most important forearm approach we all know is the Henry approach, or the anterior approach for the radial shaft. It goes from just lateral to the biceps tendon to the radial styloid, centered over the fracture or the part of the radius that you would like to do surgery on. Of course, you don't have to do the whole incision. The internervous plane in this approach, laterally it is the brachioradialis muscle, and medially it's the flexor carpi radialis distally and the pronator teres proximally. So it is the pronator teres proximally and the flexor carpi radialis distally on the medial side. On the lateral side is the brachioradialis. And remember that the radial artery lies in that interval, lies in the interval between the brachioradialis on the lateral side and the flexor carpi radialis on the medial side. Very important that the posterior osseous nerve lies within the supinator muscle in the proximal part of this incision. The supinator covers the lateral part of the radial shaft. So what you do is you need always to be on the medial side. If you're going to raise this muscle, you go from the medial side and you raise it laterally to raise it with the nerve, and the forearm has to be supinated. So in order to avoid injury of the PIN, in Henry approach, you need to supinate so that you can push the supinator muscle and the PIN away from the radial shaft. If you would like to raise the supinator, you will come on the medial side and you will release the supinator muscle with the nerve within its substance to the lateral side. This is very important. So if you remember in the first part of this lecture, we said if you're doing the coker or the lateral approach in general for the elbow, you need to keep the arm pronated so that you will push the nerve anteriorly, and you will be from the posterolateral. If you're doing Henry and you're going from basically anteromedial, you would like to supinate to protect the nerve. So PIN is protected by supination in Henry approach and pronation in the posterolateral coker approach. So let's speak now about the second approach in the forearm. So we spoke about the Henry anterior. The Thompson approach is the posterior approach. The Thompson approach goes between the extensor digitorum communis and the extensor carpi radialis brevis. So between the extensor carpi radialis brevis and the extensor digitorum communis. If you remember, in the beginning of this lecture, we talked about coker approach between the anconeus and the extensor carpi radialis, and we said if you go anterior, there is the Kaplan approach between the extensor carpi radialis brevis and the extensor digitorum communis. So this is basically the same interval as Kaplan, but more distally. Remember, the extensor carpi radialis brevis has a variable innervation, but mostly radial nerve. Ulnar, the extensor digitorum communis is basically PIN nerve. The extensor, as we said, the extensor carpi radialis brevis has different approaches, different patterns. It sometimes takes from the radial and sometimes takes from the PIN, sometimes takes from the superficial radial, but you can consider it as interneuron plane between the radial nerve through the extensor carpi radialis brevis and the PIN through the extensor digitorum communis. Again, it's the same interval of the Kaplan, but more distally. Once you retract these two muscles, once you retract the extensor carpi radialis brevis and the extensor digitorum, you will find two muscles. So if you retract the extensor digitorum communis and the extensor carpi radialis brevis, you will find two muscles. Distally, you will find the abductor pollicis longus, and proximally, you will find the supinator. So once you retract between these two muscles, the extensor carpi radialis brevis and the extensor digitorum communis, you will find two. You will find the supinator proximally with the PIN, and you will find the abductor pollicis longus distally. If you decided to release the supinator, you will do the same as you do in the Henry. You will fully supinate. So you see this arrow here. So you will fully supinate, and then you will go from anterior and release the supinator posteriorly and ulnarly, because it will have the posterior interosseous nerve here. So this is a very important concept. So in forearm approach, whether it's Henry or Thompson, if you'd like to release the supinator, or if you'd like to get the posterior interosseous nerve away, you fully supinate, and you will get the supinator muscle from as far medially as you can, and then you retract it laterally or you retract it posteriorly to go to the where it originates. So it originates from the ulna, it wraps around the radius, so you will get it as far medial, and then you retract it laterally and then posteriorly, and then aiming into the medial side again with the posterior interosseous nerve here. So both anterior and posterior approach, the safest way if you're releasing the supinator is to supinate, get the most anterior or anteromedial aspect of the supinator and release it with the nerve. So the posterior approach between the extensor digitorum communis and the extensor carpi radialis brevis, and you will find two muscles, the supinator and the abductor pollicis longus. If you want to release the supinator, you supinate as fully supinate, and then you release the supinator with the posterior interosseous nerve. Both forearm approaches require supination. Coker approach requires pronation to protect the PIN. Very important anatomical fact in the forearm anatomy is the axis of rotation of the forearm. So we know that the forearm rotates, creating supination and pronation. So what is the axis of rotation? It's very easy. It's from the radial head to the ulnar head. So axis of rotation of the forearm, radial head proximally and ulnar head distally, and the radius will rotate around that axis, creating supination and pronation. So if you see, if it's like here, the radius, and it will rotate all the way and come this way. So this is the axis that the radius will rotate. The radial head proximally and the ulnar head distally, and this rotation of the whole radius will occur around that axis, creating supination and pronation. Also, important anatomic aspect is the ulnar artery is the source of the common interosseous artery, which will give the anterior interosseous and posterior interosseous. So both interossei artery comes from the common interosseous artery, which comes from the ulnar artery. So what is the importance of this fact that the ulnar artery gives the common interosseous, which gives the anterior posterior? If you get an arthrogram in the exam and they ask you what is the artery giving most of these branches, it is the ulnar artery. So remember, the ulnar artery will give the common interosseous, which will give the anterior and posterior interosseous. So if you get an arthrogram and they point to one of the interosseous and ask you what is the origin, it's the ulnar, not the radial. There are some important anatomic facts related to the long flexor tendons of the forearm. For the flexor digitorum superficialis, remember this muscle has tendons that originate early in the forearm, and these tendons are not like four beside each other. However, the two tendons of the middle finger and the ring fingers are more superficial to the tendons of the index finger and the pinky finger, the small finger. So if you look to this figure here, it will help you to remember how the tendons of the flexor digitorum superficialis are arranged into the level of the carpal tunnel. So at the level of the carpal tunnel, you will find the tendons of the flexor digitorum superficialis, two more superficial, the ring and the middle finger. They are more superficial to the index and the small finger. So they will be arranged like this. The two of the ring and middle are more superficial to the pinky and the index finger. All the flexor digitorum superficialis is innervated by the median nerve, and they flex the PIP. They flex the flexor, the proximal interphalangeal joint, as they are inserted into the second phalanx. So the flexor digitorum superficialis will split into two tendons and will be inserted into the middle phalanx. There will be two slips of the flexor digitorum superficialis, and then the flexor digitorum profundus will go in between this. We're going to describe this more in more details when we go to the hand and wrist anatomy. The flexor digitorum profundus, which will it is deeper than the flexor digitorum superficialis, as the name says. It will give tendons much more distal than the flexor digitorum superficialis, and it will go in between the two slips of the flexor digitorum superficialis. It will insert into P3, and it will act on the DIP, the distal interphalangeal joint. Remember that the flexion of the metacarpophalangeal joint is mainly by the intrinsic muscle, which are the lumbrical and the interossei. The flexor digitorum profundus is supplied by two nerves, the ulnar nerve for the ulnar 2-digit, and the median nerve through the anterior interosseous nerve to the lateral 2 digits, the two radial digits. So again, flexor digitorum superficialis gives the tendon much more proximal in the forearm. The tendons are arranged as you can see in these pictures. The middle and the ring finger are more superficial to the small and the index finger at the level of the carpal tunnel. They're all supplied by the median nerve. The flexor digitorum profundus will split the flexor digitorum superficialis and go more distal. The flexor digitorum superficialis will be inserted in P2, flexing the PIP. The flexor digitorum profundus will go to P3, flexing the distal interphalangeal joint. For the innervation of the flexor digitorum profundus, the ulnar two sides supplied by the ulnar nerve, the ulnar two digits, the small and the ring, the radial two digits, which are the index and the middle finger, they are supplied by the median nerve through the anterior interosseous branch. And remember that the flexion of the metacarpophalangeal joint is mainly by the intrinsic, which are the lumbrical and the interossei. The flexion of the PIP is mainly by the flexor digitorum superficialis, the flexor of the DIP by the flexor digitorum profundus. I hope this lecture and the rest of the lecture will help you in your clinical work and your exam. Thank you.